copy for future reference. Okay. So we are now recording on this computer. Good deal. Okay, if everybody's ready, we'll just dive right in. Well, we're still working with the same concept of perfusion. We're going to do that for the next 5 weeks because that all has to do with the heart. And what does the heart do? The heart perfuses. Today, we're going to talk about the electrical system, though, which is going to be a lot of fun because now we get into EKG strips and all that fun stuff. And you remember this little guy? We're going to talk about electrocardiogram, which you guys will be exposed to ad nauseum in your career. We're going to talk about various dysrhythmias of the heart. And we're going to talk about one of the most common electrical dysfunctions of the heart is AFib, A-flutter. A lot of people out there, and it seems like it's growing every single day. More and more people are getting AFib. So we'll talk about that. There again, remember perfusion, passage of oxygenated capillary blood through the body tissues. You guys have probably been beat up with that one by now. Let's start with the electrocardiogram. The electrocardiogram, as you can see, you've seen this device around the hospital a lot. We even have one at the school. We have one at the simulation lab. I would kind of like to include that in our skills lab so we can show you how that works. But this is where you go and you're putting a whole bunch of these little EKG leads all over the person. Anybody who's worked in the hospital has probably seen this procedure many, many times. You take these little stickies, little square things right here. And why isn't my pen working? Let me try that again. Pen, ink color. I must have black. Anyway, well, it's not working. Stop. Right here, you can see the, let me get back to my regular pointer. Wow. Okay, let's forget that. I'm teaching a class. There we go. Now it's working. Here is an EKG monitor. You've seen that in the hospital. You take these little sticky pads and you put it all over the person's chest. There's 12 leads. There's 12 of them. One on the left arm, right arm, one on the left leg, right leg. And there's a whole row of them that go across the front of your chest. And this gives us a rhythm strip. Now, what the electrocardiogram, and this part right here, electro kind of gives you a hint. It tells you the electrical activity of the heart. You might want to remember that. Do we have oh, look at there, little angel guy. It doesn't show you mechanically what's going on. It doesn't show you what vessels are perfusing. All it shows you is where the electricity in the heart is going. The electricity, as you know, from your top of your heart goes to your SA node, goes through your atrium, goes to the AV node, goes through your ventricles and causes your heart to contract. Well, these 12 leads are measuring the path of that electricity, and it creates what's called a rhythm strip, and we'll take a look at that. We then read that rhythm strip or interpret the results, and that can tell us a lot about what is going on with the heart, to include mechanically as well as perfusion-wise. Because if you have a plugged artery in your heart, it's going to change the electrical pattern of your heart. I'll show you how that works. There again, reviewing the electrical system. Remember, everything starts at the SA node, goes through the atrium to the AV node, down through the bundle of His. The bundle of His, it's not causing any muscles to contract, it's just conducting electricity. And then when the electricity gets to the Purkinje fibers, I love that word, Purkinje. I have no idea where that came from, probably a doctor's name. Anyway, it goes into the Purkinje fibers and goes into the left bundle branch or the right bundle branch. The right bundle branch, of course, contracts the right ventricle, and the left bundle branch contracts the left ventricle. And this is when the electricity actually goes out to the cells and the heart contracts. So you have two contractions here. You have the lub dub. You have the lub of the atriums contracting, and then you have the dub where the ventricles contract. And this is a rhythm strip. You will be beat over the head with this rhythm strip for your entire nursing career. Any of you that goes on to work in cardiac, especially if you go to RN program or if you do your ACLS, you're going to be exposed to this rhythm strip. There's three parts to an EKG strip, and we've lettered them. Why they picked these letters, I have no idea, but they did. They start at P, they go P, Q, R, S, T. And what they do is they broke it up into three sections. They have the P to the R interval, which goes from here to here. They have the QRS interval down here, which is when your ventricles are contracting. And then they have the ST interval. This is where your ventricles are relaxing and repolarizing, is what they call it. Depolarizing is when the muscle contracts. Repolarizing is when it relaxes, preparing to contract again. So you have three different intervals here. You have the PR interval, the QRS interval, and the ST interval. We also call them the PR wave, the QRS wave, and the ST wave. Now, what you're seeing here, and we'll show you here in a minute, is the P wave. This is the atrium contracting. That little P wave is the atrium going boink. And then the electricity passes through the AV node and it gets to the ventricle. And this QRS are the ventricles contracting. That's why that wave is so big. Big muscle, big contraction, big electrical activity on your strip. And then the ST section right here is where your heart is repolarizing or preparing to contract again. You got a whole bunch of stuff on there. You can't see anything, can you? Well, we'll worry about that later. This amplitude is how much electricity is going through your heart, is how high it registers. And this is the time, this is how long it takes for the electricity to go through your heart. So this little graph here, and each of these has a different meaning. This box is 5 millimeters, and that counts for 0.2 seconds. So when this wave goes from here to here, it's taking 0.4 seconds for that refractory period of the heart. That's the distance this way, time. The height is amplitude measured in millivolts, so 0.2 millivolts. I don't expect you to be electricians. Don't worry about that. And you see down here the different waves. Now, what this is you have all those 12 leads attached to your chest. All these are measuring the electricity from one lead to another. For example, this is your right arm. AVR is the lead on your right arm. AV2 is the second lead on your chest and the upper part here. And they're all measuring different parts of the heart, electricity going through it. So here again, we're talking about the P wave. We're talking about the QRS, which is, this is the atrium, this is the ventricle, and this, yeah, explains it right here. The P wave, PR interval is your atrium depolarizing. Remember, depolarizing is another word for contracting. QRS is the ventricular depolarization. That's when your ventricles are contracting. And the ST wave is ventricular repolarization. The muscles relaxing, the calcium and potassium are exchanging in the cells, and it's getting ready to contract again. Remember, most of your potassium is inside the cells. The calcium is outside. So when the calcium shoots through and the potassium shoots out, your muscles contract. But then it takes time for that potassium to get back into the cell again. So this is a normal sinus rhythm strip. NSR, normal sinus rhythm. You will see that here is a normal PR interval right here. And I don't remember exactly what the number is, but you can count the little boxes. It looks like it's about 3 or 4 times the 0.6 milliseconds. Here's a QR interval, and you usually go from the Q to the R to the S. So this is the Q, this is the R, this is the S. So you measure from the R to the S, and that gives you the interval of the QRS wave. And then from that S to the top of this T wave is your ST interval. And this is what a normal heart rhythm looks like. So that is your infamous normal sinus rhythm. Now, a lot of people will listen to a person's heart. They sound normal. They have a normal beat, and they'll record on their nursing notes. The person is in normal sinus rhythm. If you're measuring a person's pulse or you're listening with the stethoscope, you don't know if that person's normal sinus rhythm or not. The only way to know if they are normal sinus rhythm is if you look at an EKG strip. So if you feel a person's pulse, you listen to them with a stethoscope and they sound normal, don't put normal sinus rhythm on the assessment. That's one of Bill's pet peeves. He says, you don't know if it's normal sinus rhythm unless you got an EKG strip. And he's right. Moving on. Characteristics of normal sinus rhythm. Your heart rate is between 60 and 100 beats per minute. This is normal, 60 to 100 beats per minute. You might want to remember that. Which would mean sinus brady would be what? Below 60, right? Sinus tachycardia would be above 100. If you remember this number, it's real easy. The SA node initiates the pulse, it travels to the AV node. Oh, here's the times right here. So your P wave is going to be 0.12 to 0.2 seconds. And then the ventricle, that QRS wave, contracts in 0.12 seconds or less. Now that we know what a normal heart does, let's talk about some of the dysrhythmias. Sinus brady and sinus tach. Sinus bradycardia is when the heart's too slow. Sinus tachycardia is when the heart's too fast. Very, very simple. Variety of things cause that. It's usually not the electrical activity of the heart that causes that. It's usually something metabolic that's causing the person's heart to slow down or speed up. Premature atrial contraction or premature ventricular contraction. I forgot to put it in here, but it's PACs and PVCs. And we'll talk more about that. And then we have the bad one. This is the bad mojo right here. Ventricular tachycardia or fibrillation. Now, those of you who took CPR, which is all of you, right? When that person puts his hand on his chest and falls over and falls to the ground, they have ventricular tachycardia or ventricular fibrillation. So this is a heart attack. That's why this rhythm is so bad. Because if that, and we'll talk about that in a minute. I'm getting ahead of myself. And then we'll talk about atrial fib and atrial flutter. Any questions so far? I'm just blazing right ahead on this.
Yeah, I have a question.
Sure, go ahead.
For the 100 beats per minute, if a patient has exactly 100, would you say that they are on the borderline for tachy?
Yeah, that's a good question. I mean, technically speaking, 60 to 100 is normal. So you could say he's normal heart rate. But I would still like point it out in my notes that is almost like pre-tachycardic, or it's a little fast for a normal heart rhythm. And but I mean, I would never put that on a test.
Oh, no, it's because it was in the assignment for April Smith and she was at 100. So I was like, was it like normal or is it like borderline tachy? So I just, yeah.
Technically that's normal, but I think borderline tachy is a good way to put it.
Oh,
very good way to put it.
Mm-hmm.
Yeah. Any other questions? Well, let's dive in. I'm going to give you some details on the sinus brady and sinus tachy. Sinus brady is like we said, it says 60 beats or less. So yeah, it's kind of ambiguous. Is 60 normal or is 60 bradycardic? One thing I would do if I'm evaluating that is If the person is 60 beats per minute and they're a marathon runner, I would say it's a normal sinus rhythm. But if the person is normally 85 or 95 beats per minute, now suddenly they're 60, then 60 is not normal for them, and I would call it sinus brady. There are athletes, the more you exercise, the more efficient your heart gets, the more efficient your heart is, the less fast it has to go to perfuse your body. So healthy athletes like long distance runners can have a heartbeat as low as 50, but that's normal for them. So you kind of have to take these things into consideration. If you're not sure if it's normal or if it's sinus brady or sinus tachy, assess the patient. And if they have symptoms, I would say it's sinus brady or sinus tachy. If it's normal for them, then it's normal. Does that make sense? You're going to get this a lot in nursing school when you start working a lot with monitors and wedge pressures and all that kind of stuff. You'll always hear them keep saying, treat the patient, not the monitor. Treat the patient, not the monitor. Because something could be wrong with the monitor. I've seen monitors show me sinus or ventricular tachycardia or ventricular fibrillation, and I look at the patient and he's sitting there reading a book. Well, it's a loose lead on the EKG that's causing the ventricular fibrillation. It's not the patient. So treat the patient, not the monitor. Moving on. Oh, here we go. Some causes for a low heart rate, healthy athletes, marathon runners, they can have a very low heart rate. So in that case, this is normal. Other orders, problems, digitalis toxicity, intracranial pressure. There's a triad they talk about with intracranial pressure, and you'll learn that in neurology. That, and I can't remember what it is, but one of the triad was decreased heart rate. So that's a really bad sign if you're dealing with, say, a head injury. And the problem, the reason it can be symptomatic is the slower the heart goes, the less cardiac output you have. So if cardiac output is down, blood pressure is dropping, all those symptoms you're going to get with that. You just have to kind of think through it. If your blood pressure drops, what happens? Dizzy, lightheaded, pale, etc. I mean, you all have seen this before, so you can kind of put it together. We have an emergency drug called atropine. If it really gets really bad in the ER, they may give them a little shot of atropine. That speeds the heart up. That's one of your ACLS drugs, by the way. Sinus tach, we're going the other direction now. It's going too fast. What could cause this? Well, of course, strenuous exercise. You know, you get done on the treadmill after half an hour. What's your heart rate, right? But I mean, that's a good thing. They say, well, you got to get your heart rate up, you know, like 140, 150 in order to get the cardiovascular benefits out of it. Other thing, obviously, anxiety, fear, etc. Anxiety and fear, you've all heard of fight flight. The sympathetic nervous system, sympathetic nervous system, basically in the fight flight. Y'all remember that, or I don't know if you've had it yet. Have you guys had that yet? No?
Yes.
Yeah.
The sympathetic, parasympathetic nervous system. Yeah.
Yeah.
So you have the sympathetic nervous system here, dumping a bunch of adrenaline into the body. You're in fight flight mode. Part of your adaptive mechanisms is to increase your heart rate so that you got more blood pumping so that you can run away from the danger, whatever danger that might be. Hyperthyroidism, you noticed the previous slide, bradycardia, hypothyroid. Thyroid controls your metabolism. If it's low, your metabolism is slow, your heart's slow. If your thyroid is putting out too much thyroid hormone, it speeds up your metabolism and your heart gets faster. That's why the hyperthyroid people are usually skinnier, because their metabolism is so fast. Hemorrhage, shock, hypoxemia. Your heart's speeding up because it's seeing that your body's not getting enough oxygen, so it compensates. The way that it compensates is it speeds up your heart rate. If the person, hopefully to get more oxygenated blood to your body, that's your body adapting to the situation. It's going to speed your heart rate up. That can be a good thing, depending on what's going on. Sometimes though, your heart is just tacking along too fast for who knows what reason. And it's electrical problem in the heart. We can use a drug called adenosine. Adenosine is really a trip. If you ever watch somebody give that in the hospital, they'll give the person a shot of adenosine and it literally stops your heart for a second, just like a defibrillator. And you'll actually see the person go flatline for like about a second. And everybody always freaks out when that happens because you got to have them on a monitor if you're going to give adenosine. And then their heart rate goes back in, hopefully comes back up again in a normal rate. So it's almost like a chemical defibrillation, if you kind of look at it that way. But that adenosine pause is what we call it when they just kind of flatline for a second and then their heart rate comes back again. Freaks everybody out. So much fun to watch the new people when they do that. PACs and PVCs. Any questions on sinus tach, sinus bradyia before I move on? Pretty straightforward. I had an ER doctor, he used to joke around. He says, ACLS, the advanced cardiac life support, is very, very simple. If it's too slow, speed it up. If it's too fast, slow it down. If it's ugly, shock it. Yeah, that pretty much summarizes all of it. Premature atrial contraction. This is when the atrium contracts prematurely. It causes an ugly rhythm. Do I have it up here? Let me see if yeah, there we go. It contracts too close to the QRS wave, and it can cause, see right here, instead of giving the full ST wave time to do its thing, it's contracting too early. See right here? And it gives you an extra wave. It's a normal pattern, it's a normal wave, but it's just, here's the distance between a normal heartbeat. This one is premature, cheap, like that. So that one is kind of interesting in that sense. It's usually an irregularity in the electrical system that causes that. But what happens is your atrial muscles are too overstimulated. And what overstimulates heart muscle? We got caffeine, we have nicotine, we have energy drinks, all that crap that our junior high kids are doing in junior high. And that is why you have so many young kids in high school and junior high coming in the hospital with PACs and PVCs because they're drinking too much of this crap. There again, hyperthyroidism, you're putting out too much thyroid hormone, speeding your system up. Any other nervous system stimulant? One that comes to mind from working in the ER, cocaine. Yep, that's a good one too. In fact, that'll just give you a flat out heart attack. So anything that stimulates the heart can cause a PAC. We're here again, we're not looking at electrical problems, we're looking at metabolic problems. You know, what's going on in the body that's causing this electrical misactivity. PVC is the same thing, only we're talking about the ventricle instead of the atrium. This is more common. You see a lot of PVCs in people. Some people will misinterpret this and they'll feel the PVCs and think maybe the person has atrial fib. Excuse me. Well, the only way to know for sure is to hook them up to an EKG. If you hook them up to an EKG, you can see flat out exactly what a PVC looks like. Now, what happens is you're having here's your P wave, here's your ventricle. So here's your atrium contracts, your ventricle contracts. Your atrium contracts, your ventricle contracts. Your atrium contracts and the ventricle contracts too soon. And what happens is you get this big, ugly QRS wave, and it even merges into the ST. They have a very distinct look to them. So, I mean, you can, anybody that's been in the field for a while will look at an EKG and go, oh, that's a PVC. It's a big, ugly QRS wave. What causes that is some of the things that cause, oh, here we go down here. Anxiety, stress, fatigue, alcohol withdrawal, tobacco use. I have seen the same things that we saw under PACs, too many energy drinks. They went to Starbucks and got 2 coffees with 4 shots of espresso in them. All that can cause PVCs too. It's not a big deal. A lot of people get PVCs, and unless you start getting a lot of PVCs in a row, it's nothing to worry about. Look for the underlying cause. Are you drinking too much coffee? Are you smoking too many cigarettes? Are you under too much stress at work? And usually once you fix those things, the PVCs will go away. They're not life-threatening unless you get way too many. Some people will feel them. They'll have like a little pallor, or they'll feel like a fluttering in their chest. And it's very similar to atrial fib. When we get talking about that, it's a very similar feeling. There again, you have to look at an EKG to see if you're talking about atrial fib or you're talking about PVCs or PACs. I'm seeing a lot more younger people getting AFib, which is really scary. I don't know why AFib has become so common. Who knows? Any question on the PACs or the PVCs before we move into the real bad mojo? How are we doing for time? Yeah, we're doing good. I'll try to speed through this though, because we're a little bit over time. Ventricular tachycardia and ventricular fibrillation. I want to show you, okay, I guess I don't have a picture of ventricular tachycardia. But basically in ventricular tachycardia, you just have QRS, 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 QRS. In fact, it looks very much like that. That is ventricular tachycardia when you see it on the monitor. And that's when something in the heart, I might have mentioned, any part of your heart can be a pacemaker. We'll sometimes put a little device in your heart that stimulates a part of your muscle to initiate a beat so that it makes the heart contract. If you have more than one of those spots in the muscle firing off at once, then the muscle doesn't know what to do and it just kind of quivers. Now here what happens is there is a part of the ventricle itself is irritated. And when it gets irritated, it starts firing off. So that little irritated spot in your ventricle becomes a pacemaker. Only he's not going at 60 or 80 beats per minute. He's going 150 to 200 beats per minute. He's irritated. He's firing off. And what happens is instead of your ventricle pumping blood, your ventricle just quivers. Now, if your ventricle is just quivering, or in this case, it's going so fast, it doesn't have time to refill, what happens? No blood to the body. No blood to the body, what happens? Boom, fall down, boom, you're out of it. This is where you're grabbing the AED or the defibrillator and you're shocking them, because we want to stop the heart from doing that. And then hopefully after the heart stops, it goes back into a regular beat. I'm sure they talked about defibrillator in your CPR training, right? Does anybody have any questions about defibrillation? We'll be talking more about that, I think, when we get to like week 10. But anyway, you have a single irritable spot on your ventricle that starts going crazy. And that kicks you up to about 150 to 250 beats per minute. You are not, it says cardiac output decreased. At that rate, you're not getting any cardiac output at all. You're basically, your blood is not flowing. You're going to fall over, boom. And if somebody doesn't do something quick, you're going to be dead. This is classic. Now you're thinking, okay, what causes an irritable focus? Well, getting a blood vessel in the heart plugged, an MI, myocardial infarction, a heart attack. You plug off a blood vessel in the heart, and that part of the heart downstream from the blood vessel is not getting any blood. It's not getting any oxygen. It gets irritated and it goes crazy. And that's what causes your irritable focus. Client will probably, now, if they're tacking along at 150, they're probably still going to be awake, but they're not going to feel good. They start getting up around 250, they're going to pass out. And it can lead to ventricular fibrillation, which I'm going to talk about here in a second. So if their heart rate starts increasing and increasing, it's an emergency. It's a dire emergency. Now, ventricular fibrillation, that is an all-out, full-blown heart attack. What's happening here, and let me show you, is this focus starts going wild. It starts aggravating the rest of the heart. So now this part of the heart's contracting, this part of the heart's contracting, this part of the heart's contracting. Basically, the whole heart's just going crazy. And this is your rhythm right here. Utter, total, 100% chaos. That is a classic atrial fibrillation pattern right there. And that's why I was saying for ACLS, you know, if it's too slow, speed it up, too fast, slow it down. If it's ugly, shock it. And this is ugly right here. This is the definition of ugly. So going back, the rhythm of a dying heart, this is classically, this is caused by myocardial infarction, when your blood vessels got plugged in your heart and your heart is not getting the oxygen it needs. There again, if you have a lot of PVCs and they're starting to line up, you get a lot of PVCs lined up, basically you've got ventricular tachycardia. But if you have a lot of ventricular tachycardia, I mean, he's really clicking away at about 200 beats per minute, it can eventually degrade into atrial fibrillation where the heart just goes crazy and starts quivering. And then you have an all-out heart attack, a cardiac arrest. Treatment, if you don't have a defibrillator, you do CPR. If you do have a defibrillator, you use it. Like I said, what you want to do is you want to stop the heart, stop these little foci here from firing off. And the defibrillation just sends a huge shock wave through the whole heart and it stops the heart completely. And then hopefully the only one that starts back in again is your SA node and you go back to a normal rhythm. That's what you hope for. 90% of the time, that's what happens. How long they stay in that rhythm, well, that's when we start doing other drugs and stuff to try to keep them in that rhythm. And you'll go into all that stuff when you do ACLS. Pharmacology, let's talk a little bit about the drugs. Now, for those emergency situations we were talking about, when the person puts their fist over their chest, they fall over, they land on the ground, you start doing CPR, they find an AED, they bring the AED out, they put them up, they shock them. Okay, now his heart is back to normal. The problem is, what caused that heart to go crazy in the first place, and have we fixed it? Probably not. What is the likelihood that he's going to fall back into ventricular tachycardia or ventricular fibrillation again? Real high. So we have drugs that the paramedic or the emergency room physician will administer, or you will administer if you are the first person at the scene of a code and you've been ACLS trained, you would be administering these drugs. One of those is epinephrine. Epinephrine is our first line drug. That's the first thing we always give in the event of a heart attack. And what it's supposed to do is help increase the blood flow. Epi is like adrenaline. It opens up the vessels. It gets oxygen flowing. When somebody falls over and we start CPR, what organ of the body are we trying to preserve? Anybody know?
The brain.
Brain. You got it. Even though you're on your cell phone, you got it. We're trying to get oxygen to the brain. The lungs, the heart, these are just a support mechanism for the brain. Everything in your body is just a support mechanism for your brain. Your brain dies, you're toast, you're done. So we're trying to get oxygen to the brain. So epinephrine is the first thing we use to try to keep that oxygen flow going to the brain. I keep grabbing my mouse, it's not connected to my mouth. The second thing we will try are lidocaine and amiodarone, usually lidocaine first. If it doesn't work, we try amiodarone second. And what this is once we shock that heart and get it back into a normal sinus rhythm, we want to give the person a drug to stabilize that rhythm, to hopefully calm the heart down so that it doesn't get irritated and go crazy again. And that's the best way to think of the antidysrhythmic drugs, is they're just trying to stabilize the heart so that it will stay in a normal sinus rhythm. And that's why we usually, lidocaine is always the first drug we try to do that. If the lidocaine's not working, we move on to the amiodarone. But that's what we're trying to do with these drugs here. And these are the three drugs that you will find. There may be others. There are some other drugs. You'll find the atropine or in some other stuff in the crash cart also. But these are our three primary drugs for a heart attack or myocardial infarction, is these three drugs right here. We used to have an old acronym, ALE, as in beer, ALE. That's how you remember the three primary drugs for ACLS. You can remember that. You might want to know that. ALE, remember ALE, Liechtenstein, ALE. Okay, any questions on any of those heart rhythms before we move on? Now, a lot of this was probably covered in CPR, although CPR training really doesn't go into, and I think it doesn't go into the rhythm strips or anything anymore. We used to teach a lot of that in CPR, but they've stripped CPR down and simplified it a lot. But no questions? The last thing I'm going to cover, and then we'll get out of here, is way over. Atrial fibrillation. Now, there's two kinds of there's two different kinds of atrial fibrillation and atrial flutter. We treat them both the same way. It's just a different rhythm on the rhythm strip, basically, and I'll show you what each of those looks like. But basically what happens is your atrium of your heart is going crazy. Basically, your atrium in atrial fibrillation, which is the most common form of atrial fib, atrial flutter. Atrial flutter is not as common as atrial fib. Atrial fib is very common. But basically, the atrium is just kind of quivering because it's got too many of those irritable foci we talked about going off. You're getting too many pacemakers in the atrium. The atrium is irritated for some reason. High blood pressure is a very common cause of it, but there are several pacemakers going off in the atrium. So the atrium is not pumping the way it should be. It's just kind of quivering. Fortunately, we have an AV node, and that AV node keeps all those impulses from shooting into the ventricle so that your ventricle becomes ventricular fibrillation, because that would be life-threatening. Atrial fib itself is not life-threatening. I mean, a lot of people live with it. They walk around with it every day, but it can have some bad side effects, and I'll probably tell you about that. What happens though is when the ventricle, when the atrium is doing all its weird stuff, is just kind of the AV node keeps all those impulses from getting through, but it lets a couple of them through to keep the ventricle beating. So what you're going to have is a very irregular heart rate. It's just not going to be anywhere near any kind of normal rhythm. It's just kind of, it grabs a stimulus from the atrium, goes to the AV node, and it contracts, and then it just kind of waits for another one. It's very irregular. The life-threatening complication about having atrial fib is while that atrium is sitting there quivering, it's not pumping the blood properly, and blood is pooling in the atrium. Did I have a diagram for that here? Yeah. You can see that they have all the different atrial foci going off. This one's going off, this one's going off, this one's going off. And it could be up to 400 beats per minute, which is crazy. But fortunately, the AV node right here keeps that in check and only lets a few of them through, enough to keep your heart rate going at a rather normal pace. But while it's quivering, blood will pool up here. And if that blood pool, what happens when blood sits still? Anybody? If you
Coagulates.
bleed on the counter and that blood sits on the counter, what happens to it?
It clots.
It clots. It becomes a gel. So your blood is sitting here doing nothing and you get these little clots forming. Then all of a sudden your atrium decides to contract. What happens? Boom. That blood clot shoots into the ventricle and your ventricle shoots that blood clot out into the body and all kind of bad things can happen. It can go to the heart and give you a heart attack. It can go to the brain, cause a stroke. It can go to the lungs, cause a pulmonary embolism. That's bad. And so how do you think we keep those blood clots from forming?
We give aspirin.
What's that?
We give
Medication.
medication
Medication.
like warfarin and aspirin.
Blood thinners, warfarin, you got it. Let's thin that blood out so that we lower their risk of getting a clot. So that's where the atrium, now every once in a while, especially if a person is new to atrial fib, all those electrical impulses shooting through the AV node, the ventricles might try to keep up. They might try to keep up. And what happens then is their heart rate goes up to, I think the average is 140 to 160 beats per minute. And when that happens, that's called atrial fibrillation with rapid ventricular response, or AFib RVR. You'll see that thrown around a lot. Now, when it gets to be that bad, then we really need to do something. And it's usually an intervention of some sort. That intervention can be a controlled defibrillation, cardioversion. That's the word I'm looking for. Or we can give them medication for it. But a person, like I said, a person can walk around the street and not even know they have atrial fibrillation and not think about it. Now, I happen to have it as well. And when my atrial fib kicks up, I can feel it in the chest. It's like a weird flutter in my chest. And my cardiac output is reduced by about 20%. So I get winded real easy. If I'm out hiking or doing any exercise, I have to sit down. So usually a person with atrial fib will feel it. And I have what's called intermittent atrial fib. So it only happens once in a while. And I take a medication that keeps that from happening. So as long as I'm on my medication, I don't get atrial fib, which is great because now I don't have to be on a blood thinner. Now, if you have atrial fib all the time, then you have to be on the blood thinner. And we'll talk more about that here in a second. But this is what that looks like. You'll notice between each ventricular contraction, the pattern is totally irregular. There's no regular pattern. And remember the P wave, the PR interval right here, P to, or not P. Anyway, this interval right here where the atrium contracts, you're going to have P waves all over the place. And they're all going to look different because they're all originating in a different spot. So you're going to have all this erratic pattern of P waves here. And this is classic atrial fibrillation right here. You'll have to look at my slides because when you look at this, I write all over everything. Yeah, okay, here it's just saying that there are impulses outside of the ESA node causing that thing to contract anywhere from 200 to 400 beats a minute. So that's basically the atrium is just fluttering. It's not doing anything useful. Now we get on to atrial flutter. Atrial flutter is pretty much the same thing as atrial fibrillation. It just looks different. Now, in this case, what's happened is you have a single irritable foci in the atrium. So you get a regular looking pattern. And what we call this is sawtooth because it looks like the teeth on a saw. So this is what atrial flutter looks like as opposed to atrial fibrillation. In fibrillation, it's all erratic and ugly looking. With flutter, it's a consistent looking P wave. And that means you have a single foci in the atrium that's going off as opposed to the atrial fibrillation, which you have several foci going off all over the place. We treat them the same. The side effects are the same, the drugs are the same, the characteristics are the same. They just look different on the EKG. So how do we assess it? ECG. Then that's how we look at it. You probably hear people say, and you hear me slip quite often and say EKG. That's because the EKG is the German name for the electrocardiogram, and they spelled it with a K. And early on in medicine, when this first came out, everybody was calling it an EKG. Technically speaking, it's an ECG, unless it's a German machine. Just kidding. Characteristic of atrial fib is an irregular pulse. I do that all the time. You'll see me walk into a patient's room, do an assessment. I'll listen to their heartbeat, and I take their radial pulse, and it'll be going bump, 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 kind of like classical music. And I'll look at them and go, you have atrial fib. And sometimes they say, yeah, I do. Or sometimes they say, no, I don't. If they say, no, I don't, then I try to suggest to the doctor that he get an EKG and get diagnosed so that he has that on his sheet. And I already told you about this right here. Cardioversion. If your heart rate's getting up around 100, 120, 130, what we do is we hook you up to the defibrillator at a very, very low voltage, and we zap you. And hopefully what that does is that causes the atrium to stop for a second and then go back to a normal pattern. Same as we do for someone in a heart attack. The only difference is it's a much, much lower voltage. We usually give them a little Valium or something first because it's a little uncomfortable. Or surgical management. And that's where the cath lab goes in, and it's also called May's procedure. It's also called an ablation. There's a little difference between those two, but I'm not going to worry about that. But basically what we do is, does it show it? No, I don't have one. But basically we run a catheter in and we run an electrode up to the atrium. We try and find out where that atrium is excited, and they just zap it with electricity and kill that area so that it will quit sparking. And basically we're scarring that tissue right there, so it'll quit acting like a pacemaker. Far more effective with atrial flutter than atrial fib, because atrial flutter, you're only dealing with one location. Not very common. Cardioversion, I have a funny story about that if anybody ever wants to hear it. I had an electrician come in to cardioversion. He said, I've been electrocuted dozens of times. Don't give me the Valium, just give me the electricity. We zapped him. He said, okay, I'm okay now. Weird. As we were talking about, heparin is a blood thinner we use in the hospital. We don't send people home on heparin, but we do send them home on Coumadin or warfarin. And that's if the dysrhythmia continues and we can't get it under control. We can use amiodarone. We can use flecainide, which is my drug of choice, or this one here, ibutylate. I haven't seen that a whole lot. In fact, I haven't seen the one I use a whole lot either. Amiodarone is mostly the one we use. And this is an anti-dysrhythmic drug that's supposed to just get the atrium to settle down and go back into a normal heart pattern. For some people, it's very effective. For me, this drug was extremely effective. I've been on it for like 10 years now. It works beautiful. Nursing management. What are you going to deal with? Decreased cardiac output. You want to keep an eye on their vital signs, no changes in mental status. They can get irritable, or they can get very dizzy and faint if the cardiac output drops. They may need some bed rest because they get up and move around with decreased cardiac output. They could fall over and go boom. Falls are a very bad thing in the hospital. And deficit knowledge. We need to educate them on why they could wind up getting a blood clot because of their atrial fib, and why it's important that they take their anticoagulant medicine. And they want to be sure to let their doctor know, especially if, like me, you have intermittent periods of AFib. You want to keep your doctor posted so they know if your anti-dysrhythmic drug is working effectively or not. I think that's all I got. Anybody have any questions on atrial fib or atrial flutter? I'll go back to this. Okay, if there's no questions, I'm going to turn the recording off right now.
Quick question.
Go ahead.
Do you think that COVID is actually impacting a lot of people's hearts in that manner? I'm not sure if you can answer that, but. 'cause
I
it's all-
don't know for sure, but I would be surprised if the heart is not impacted because of COVID, because COVID mostly hits respiratory.
Right,
But
right,
respiratory affects your heart too, you know.
exactly.
People with COPD develop right side heart failure.
Yeah,
So, and I think people with weak hearts are at a much, much higher risk of dying from COVID because of that. The respiratory distress just puts too much of a load on their heart. So I would say definitely yes, definitely.
okay, all right. I think so too. Thanks.
Any other questions? Okay, I'm turning the recording